All right, everybody, we only have one more talk before lunch, but I will tell you it's going to be worth staying in the room and not missing this before your lunch. So I have the pleasure now of introducing to you Dr. Angela Lowenstern. She is Assistant Professor of Medicine at Vanderbilt Medical University, and she's going to talk to you about the procedure of the decade here. This is the procedure that every cardiology fellow wants to eventually grow up to be able to do, and that is complex cases of TAVR, the evolving role of TAVR for treating aortic stenosis in women. Welcome.
Hey, nice to meet you. Thanks so much. And this is, press this forward. Okay. Thank you, everybody. I'm excited to be here and get to be the last talk right before lunch, but hopefully should be a good one. So I get to talk to you about something that's very near and dear to my heart, which is TAVR, which I really love, and I am one of those people that wanted to grow up and do TAVR, and now I get to do it. So no relevant disclosures. Here are the learning objectives, but I'm not going to read them off. You can take a quick look at those. But really, I want to point out that this is going to be case-based. So I'm going to go through 2 cases of patients that I saw in clinic, and then we're going to talk about different aspects of TAVR. And so the first case is a 76-year-old woman. She came to Valve Clinic for evaluation of aortic stenosis. She told me that she'd had progressive shortness of breath. So it initially started a few months ago. At that point, it was really only with heavy exertion, but more recently, she gets short of breath with minimal activity, even walking across the room. She also has now developed chest pain with activity and no lower extremity edema or syncope. She does have a history of coronary disease. She had a 4-vessel CABG a number of years ago. She has known ischemic cardiomyopathy, hypertension, hyperlipidemia, diabetes. She previously smoked, 40-pack year history. She quit many years ago. And she lives at home with her husband, and she's independent. On exam, she's hypertensive. She has a classic systolic murmur consistent with aortic stenosis. And on her labs, her BNP is elevated at 580. So she comes to me and she's had an echocardiogram, and on the left you can see that her LV function is reduced. Her EF is about 35%. Her aortic valve is calcified, and her gradients are elevated, but maybe not to the extent that you might imagine. So her aortic valve area is 0.8, which is in the severe range, but the peak gradient is only in the 20s, and peak velocity just over 2. And so there's discordance in her numbers. And so this is a low flow, low gradient state, and somewhere where we need more information to be able to diagnose and treat this patient. And so I'm going to leave this here, but we'll come back to our patient in a few minutes. So let's talk about aortic stenosis, the prevalence, the burden, and the ongoing gaps really in care. So we know aortic stenosis is a prevalent disease and that the risk increases with age. The left graph shows the risk over a decade of life from people in their 60s up to their 80s. And you can see that risk, the prevalence increases with age, and particularly the number of patients with severe aortic stenosis. The graph on the right shows similar patients in their 50s up to their 80s, and the increasing prevalence, kind of that exponential top line with age of severe aortic stenosis. But the incidence of surgery does not match that prevalence. And so what is the natural history of aortic stenosis? We know from Braunwald's initial observations, the graph on the left, that aortic stenosis follows this long latent period where patients have increasing obstruction, and then they have an onset of symptoms when they reach a critical point. And at that onset of symptoms, we know that by 5 years, if no intervention is performed, over half of people will have died related to their aortic stenosis. And so this really is a morbid condition, but fortunately we have really good treatment options. And so on the right here is data from the Partner 1 trial. These were patients that were inoperable. So these are the highest risk patients, and even among those high-risk patients, TAVR significantly reduces the death from any cause compared to medical therapy. Unfortunately, we also know that a high proportion of patients still are not treated. So this is a study that we did that used insurance claims from over 2,000 hospitals across the country, looking at the treatment rate of men and women with aortic stenosis. And what we see is that while the treatment increases from 2011 to 2016 with the introduction of TAVR, that over 60% of people in 2016 with severe symptomatic aortic stenosis were not treated with either TAVR or SAVR within a year of diagnosis. And so there's a really big gap in treatment that we really need to address. So thinking about why that gap may exist, pre-TAVR availability, it was all about thinking who is a surgical candidate and who is not. And so this was a study looking at reasons to defer treatment or defer surgery. And unsurprisingly, age, comorbidity, neurologic dysfunction, heart failure, known EF less than 50% were all factors that reduced the likelihood of getting treated with surgery. But TAVR is a great option, right? And so all the patients that couldn't have surgery should get TAVR. Well, this is a study done by Sammy Almira and looking at data from Mass General and Brigham Women's, looking at treatment with TAVR availability. And so on the left in orange are patients with a class 1 indication for aortic valve replacement, and on the right in blue is a class 2 indication for aortic valve replacement. And what we can see on the left in the top figure there is that even among patients with classic aortic stenosis, normal ejection fraction, high gradient, 30% of those patients were not treated with an AVR. And then among patients with a low ejection fraction or a low flow, low gradient, like our patient, anywhere from 47 to 67% of those patients were not treated. And so there's a lot of room for improvement, but let's talk about how we identify aortic stenosis and how we can get these patients in to be seen in the right place so that we can get them treated. So identification really is generally by physical exam, a good cardiac exam, listening for that murmur, or sometimes we do detect aortic stenosis on somebody who gets an echocardiogram for maybe another reason. Evaluation consists of non-invasive imaging with echo, sometimes a stress echo, sometimes invasive hemodynamics to further clarify, and calcium scoring on CT can also help identify how severe is this aortic stenosis. Once we have that information, an STS risk score can help with risk stratification, and then we put all this data together as a heart team and discuss treatment for patients. We know that aortic stenosis is progressive and that there are different stages, and so there are patients just at risk or stage A, all the way up to stage D, which is symptomatic severe aortic stenosis. And the guidelines would recommend different monitoring and follow-up depending on the severity of the aortic stenosis. And so somebody with mild aortic stenosis doesn't necessarily need an echo every single year, but should be closely monitored and have an echo every several years. By the time somebody reaches severe aortic stenosis with symptoms or their ejection fraction starts to drop, that's when these patients really should be referred to a heart valve team and have a heart team discussion about treatment. So what do we do when we see patients in the valve clinic, and what kind of workup do we do? So echocardiography is really going to be the first step of identifying the aortic stenosis. Everybody that comes to my clinic gets a TAVR CT scan if they're going to be a possible candidate for TAVR. We use this in many different ways. So we look at the calcium score on the aortic valve. We are able to use it for sizing considerations of the aortic valve for TAVR. We can identify any aortic pathology, such as an ascending aortic aneurysm. And then, of course, we want to look at vascular access. So can we do a transfemoral approach, or does this person need an alternative access approach? We also use the CT to look at the coronaries. We're not doing a heart catheterization on every single patient anymore. If the CT shows minimal coronary disease, then we can skip that step. But sometimes we still do need to do that cardiac catheterization and look for severe coronary disease prior to TAVR. Other tests, we look at EKG for conduction, laboratory assessment, pulmonary function tests, dental evaluation. We want to make sure that there's no active infection. And then we have a big heart team discussion, including any unique clinical considerations for the patients. So let's take a step back and just think about different considerations for women specifically. And so this was a study looking at how do patients with aortic stenosis present, and how is it different between men and women. And what they found is that women in general present and they're older, they have a lower BMI, are considered more frail, more kidney disease, a lower GFR, higher rates of anemia, and more advanced NYHA class symptoms. And so it seems that women are maybe presenting later. And this was another study also looking at symptoms and comparing men versus women. Women are in blue and male patients are in red. And what we can see is that women were more likely to have symptoms. And when they did, these were more likely to be shortness of breath and dizziness or syncope. And this held consistent across all patients and then also the subset of patients over 80 years old. Other considerations for women with aortic stenosis is that the ventricle doesn't respond in the same way. And so women are more likely to have concentric remodeling versus men have eccentric. And women are more likely, just like the patient that I showed you, to present with low flow, low gradient aortic stenosis. Similarly, valve calcium scoring is not the same for men versus women. Women are more likely to have fibrous valve changes, and a lower calcium score is considered to be severe for women compared to men. So coming back to our patient, so she had symptoms of aortic stenosis, a peak velocity less than 4, but an area of less than 1, so that's a discordance in those measurements, an ejection fraction of less than 50%, and so the guidelines would recommend a dobutamine stress echo as the next step to further delineate severity of aortic stenosis. And so the dobutamine stress echo was completed. This was at 5 micrograms of dobutamine. You can see the gradients are still between peak velocity between 2 and 3. But once she got up to 20 micrograms of dobutamine, then the peak velocity did reach 4 meters per second. And so she was able to be treated with a balloon expandable sapien valve, and she felt better. Her symptoms really improved. And so a good example for getting more imaging, particularly when there's discordance in those measurements. All right, let's look at our second case. So this is a 70-year-old woman who presents, again, for evaluation of aortic stenosis. She tells me she's had a heart murmur for many years, but more recently she's had progressive fatigue and shortness of breath. She had undergone a percutaneous coronary intervention with another interventionalist prior to seeing me and didn't have improvement in her dyspnea. She tells me that she's done all of her homework and that she wants a TAVR, not a SAVR. She does have, again, a history of coronary disease, hypertension, COPD, and then left breast cancer, which is in remission. And her exam is notable for a systolic murmur. So this is her echocardiogram, which shows a normal ejection fraction and a calcified aortic valve. And she has high gradient aortic stenosis, so more of that classic aortic stenosis. And so we talked about how aortic stenosis presents, what workup we do, but let's talk about treatment for aortic stenosis. The timing of treatment is really key. You don't want to treat somebody too early, put them at the risk for their procedure, and then put them also at risk for needing a second procedure down the road. But you also don't want to wait too long where the heart has really decompensated and has irreversible damage. And so there's this Goldilocks timing for treatment of aortic stenosis. And the COVID pandemic actually gave us a really interesting peek into this. And so at the beginning of COVID in 2020, ACC and SCAI issued this joint statement on how we treat patients with aortic stenosis during that pandemic. And so they said that highly symptomatic patients with aortic stenosis should have a TAVR, and that those with minimal symptoms really could have close monitoring or TAVR. And retrospective review of this showed that while not statistically significant, the curves do separate even at 30 days for patients that had deferred treatment and higher risk for having events. So what are the treatment options? So we talked a little bit about this already, but surgical or SAVR, and then percutaneous or TAVR. Surgical aortic valve replacement is, I always talk to patients about, a higher upfront cost. It's an open heart surgery. You can do other procedures at the same time. If you need an ascending aortic repair, if you need a CABG, other things, you can do kind of all at the same time, but it is an open heart surgery. We think about surgical intervention for patients maybe that do have multivalvular heart disease or younger patients, those less than age 65. For TAVR, it's a transcatheter procedure. You can do other coronary interventions either at the same time or a staged procedure, and there's a much shorter recovery time. And so most of our patients come in the same day of their procedure and go home the next day. There are unique considerations for young patients. I always tell patients that are kind of on the younger age spectrum or maybe really insistent on TAVR, even less than age 65, that it's much easier to put a TAVR valve inside a surgical valve for a second procedure down the road than it is to put a TAVR inside a TAVR. And so this is just a graph showing the kind of evolution of TAVR availability over time from high-risk patients only in 2011 to now since 2019, really patients at all risk statuses can get TAVR. And so what happens after TAVR? What are the outcomes? And we'll take a quick peek at how women do compared to men as well. So this was a study that we did that looked at male and female patients who underwent SAVR and TAVR, coming back from the data I presented a little bit earlier. But we showed that female patients overall are treated less than men, and that when they are treated, they're more likely to undergo TAVR versus SAVR. And this has important impact on outcomes. And so untreated patients, as you can imagine, have equally poor outcomes. But when treated, female patients we saw had worse outcomes than men. And this was driven by a higher risk of mortality after SAVR in women. And other studies have shown this as well. So this is a study looking at outcomes after SAVR. They noted similar baseline characteristics that we talked about earlier, that women presented with more dyspnea, higher frailty, and more severe aortic stenosis. And they did worse after SAVR than male patients. But fortunately, we have TAVR. So this is data from the partner trial. Female patients are on the left and male patients are on the right, looking at TAVR versus SAVR. And what we can see in that left graph is that women who underwent TAVR had significantly lower rates of 2-year death than those who underwent SAVR. In the core valve trial, men and women both benefited from TAVR. On the left is all-cause mortality, and on the right, cardiovascular mortality. And you can see similar outcomes between men and women. And then this is low-risk data. So this is data from the PARTNER 3 trial and the Evolute low-risk trial. So on the left is surgery versus TAVR for low-risk patients. And we can see that while not statistically significant, numerically lower risk of an outcome in patients who underwent TAVR, and similar in the Evolute low-risk trial. What about real-world data? So this is from the TVT registry, looking at men versus women who underwent TAVR. Similar to what we've already talked about, female patients were more often deemed frail. They more often needed alternative access, so non-femoral access. They had an increased rate of vascular complications. They had more coexistent mitral disease. But yet, despite all of those things stacked up against them, they had higher survival at 1 year compared to men who underwent TAVR. This was a meta-analysis that included over 11,000 patients looking at male versus female patients who underwent TAVR. Female patients were more likely to have major bleeding and stroke during the TAVR procedure, but in late outcomes, looking out to 5 years, women had greater survival than men. So really, TAVR is a great option for our female patients. So let's come back to our patient. So she had her CT scan done, and these are a glimpse at some of the pictures that we look at trying to size our TAVR valves. And what it showed is that she was what we would consider a small annulus female. So women are more likely to have a smaller annulus than men, and this has just different considerations into which TAVR valve we might choose. So we had a heart team discussion. Her STS risk score was 3.9%. We reviewed her CT anatomy. And we took into consideration, of course, her preference that she wanted a TAVR. And so she underwent a TAVR with a 23-millimeter Evolute Pro Plus valve. And she did very well. So what do the guidelines say? So the guidelines tell us that we should look very closely at our patients with aortic stenosis, and that anybody with symptoms related to aortic stenosis, whether they meet that high gradient or perhaps the low flow, low gradient, can have an AVR with a SAVR or a TAVR. You really want to think about this in patients over age 65. Less than age 65, you're going to think much more towards SAVR only, depending on patient comorbidities. And then just briefly at the end here, I just want to talk about valvular heart disease and pregnancy. And so ideally, this is from the guidelines as well, ideally we would identify valvular heart disease before pregnancy and be able to intervene and manage the valvular heart disease before. But in the cases where we do not identify valvular heart disease before, there's a 2A recommendation that in pregnant women with severe AS and severe symptoms, either hemodynamic deterioration or NYHA class 3 or 4 symptoms, those patients can have valvular intervention during pregnancy. There's also a class 3 recommendation for harm that we should not be doing these procedures if patients don't have those kind of severe symptoms. And so some really just broad key points to take going forward in clinical practice. Symptoms are really insidious, and female patients have somewhat different symptoms than men. A lot of times I hear in clinic patients say, oh, I'm just worn out, I'm just getting older. And so it's important to just keep a high index of suspicion because we really can make a difference by treating these patients. If you're ever uncertain, order an echo, and if there's ever discordance in those measurements and you're not sure what to do with it, send the patient my way. Send them to a valvular heart disease specialist. And then be an advocate for your patient. So that's kind of the most important things. And then I have to say, it's just such an exciting time to be somebody doing structural heart disease interventions. So these are just an example of some of the upcoming things. So the left two valves are the new valves, the FX Plus, and the Navitor valve. And you can see that they have larger frames to be able to access the coronary arteries. And then on the right are the new Evoke valve and TriClip for tricuspid interventions. And those were both just FDA approved in the last 2 months. So very exciting. And that's it. I'll get everybody to lunch.